Public health specialist Dr. Nicholas Crisp is Deputy Director General in the National Department of Health. He joins us now to reflect a little bit more on the summit. A very good evening to you. Thank you so much for speaking to us, Dr. Crisp. I'm just looking at some of the World Bank statistics saying that South Africa is one of the most unequal countries in the world. We know that. But it's saying that with race playing a key role in a society where 10% of the population owns more than 80% of the wealth. What exactly does that mean? Does it mean the access or the institutions?
Good evening, Chapisa, and good evening to the viewers. So what we are hearing in those figures from the World Bank is to do with the economy of the country. And what we know is that we are ranked as the most unequal society in the world. There's an index called the Gini coefficient, where you measure the either the wealth or the income. There are two separate ways of measuring it, where a number of indices are put together to see what is the difference between the worst and the poorest and the richest people in a country. And our differential shows us that the richest portion of the country is far wealthier than the poorest compared with any other nation in the world. There are a couple of other Southern African countries that are close to us, but otherwise nowhere in the world is nearly as inequitable in terms of access to resources, wealth, and that includes healthcare.
I mean, no doubt COVID-19 displayed to us so very vividly not only the weakness in the health systems, but the burden on particularly the public health system. If we're told about 15 to 20% of the population is actually served by the private sector, can you share with us how the public sector is weathering the storm? And are you able to meet the demands? I was just quoting a figure earlier on saying that less than a quarter of hospitals are actually on the grid. They are actually able to operate during load shedding.
Yeah, so let's take a step back and have a look about where's the money and what do we spend in healthcare? So we spend a lot of money in South Africa. We are amongst our peers one of the greatest spenders on healthcare as a nation. We spent last year 8.9% of our GDP on healthcare, and that 51% of that was spent in the private sector, the vast majority, 83% of that, in what we call voluntary contributions or medical scheme payments, and the remaining portion largely on what we call out-of-pocket spending. Now that is mostly spent on 15 to 20% of the population. We know that people spend out-of-pocket over and above their medical schemes because they take packages that don't cover all their healthcare needs. And we know that there are people who become desperate, who are dependent on the public sector and raise money, sometimes incurring tremendous financial hardship to get access quickly in the private sector. So we are spending a huge amount of money. That amounts to 556 billion rand spent last year. Now the problem is that only in the public sector we spend about 5,200 to 5,300 rand per annum per capita, and in the private sector we spend over 26,000 rand per person per annum, and that's the differential. That's the size of the difference. So 15 years ago we were spending 3.5 times more in the private sector per capita than in the public sector. It's now 5.5 times more. It's not sustainable. This divergent graph, where the private sector continues to spend money, raise its tariffs, increase the resources and suck them out of the public sector and leave the public sector to look after the majority of the people, has got to implode at some point. And we are cautioned from countries elsewhere in the world that this is unsustainable and we need to do something drastic about it. So that's what national health insurance is about. In order to ensure universal health coverage, our goal across the world on universal health coverage is that everybody, irrespective of who we are, must have the access to the healthcare we need, when we need it, where we need it, without incurring financial hardship. And to do that, we know, and it was explained to us by colleagues from Geneva today, we need to pool our resources into a single payer, and we need to share the way in which we spend these resources far more effectively without the duplicative systems and the wasteful administration that goes with them. So that's what this is all about.
So this single payer, single purchaser model that we are trying to build, the minister says that we're almost at a point where this could be taken to the National Assembly and tabled there, but it needs to provide a framework for unified funding. How are you going to do that, given the criticisms that there have been in the past?
So the way these things work is they work in bite-sized chunks over a period of time, and one starts with the low-hanging fruit. So at the moment, there's about 250 billion rand in the public sector. 60 billion of that is in conditional grants, which are relatively easy to move into a central pool. And the remaining portion of that money is a little bit more difficult. It sits in the provincial equitable share, and it needs to be moved systematically over time once the mechanisms are in place to purchase the benefits through the single fund. So that won't happen in a short space of time. There are also smaller pools of money sitting in correctional services and in the road accident fund and so forth. But we also have a lot of money sitting in the private sector, and we have to carefully move some of that money. The easiest portion of that money to move is the 34 billion rand tax credits, which the global economists cannot believe that we still give back to private sector members. None of us understands why that is a logical thing to do. And so from a health perspective, that is part of our discussion with Treasury, is to move that benefit back into the health sector as part of the National Fund. The next thing one needs to do is to move the portion of the employer contribution, particularly to public servants' medical schemes, into this fund. But you can't do that. You can't make those moves until the fund has got the capability to pay for benefits. It must have its defined benefits that are included in that in those requirements, and it must have the capabilities to measure, pay, and to have the necessary delivery system through the providers of healthcare. These things take time to put into place, but we need a statutory framework. You can't implement these reforms without the statutory framework. So that's what the minister's talking about. We have been participating in the parliamentary process. The Portfolio Committee has been debating this for a long time, and we have responded on the 30th of November to the final clause-by-clause discussions on that bill. Now it will go to the vote very shortly.
And on the financial risk protection, that's a question that many have been asking, as you've just outlined some of the solutions that you're possibly thinking of engaging.
Yeah, so as I said, it's a slow but sure stepwise change in the way that we fund things at the moment. So Section 32 of the bill deals with how we move money in the public sector from the current many different allocations, largely through the provincial equitable share and the conditional grants, as I said, into the fund. And the mechanisms of doing that are explained in Section 32 with the amendments that brings to the National Health Act, which are in Schedule 1 to the bill. Section 33 deals with how we move money in the private sector and what the private sector finally will be delivering once all the benefits are defined within the space of the National Health Insurance Delivery System. That could be many years before that happens. And that is also elaborated on elsewhere in the transitional provisions and in the funding clauses from Section 49 onwards. So the bill provides the framework to make the changes, but everybody seems to think that suddenly this has got to be in the context of the economy of 2022 or 23, and are very hesitant to accept that the bill speaks about a much longer time frame with a phased-in implementation of these various mechanisms.